Plan for the rest of the class, this is going to be very brief. We can either go into next week to help alleviate possibly that Friday. That way we move our lab to after our test following week. Touch and go that. So this is going over what history has been. Obtaining a patient's chief complaint, recent illnesses, and significant past medical history are obviously important. You need to know what they've had in the past, to know what we could be dealing with now. Obviously, some of this is going to be, a lot of what we deal with is acute, but a majority of it's going to be chronic as well. Foundation, providing good care. Asking the appropriate questions or how you're going to find out about their previous history. Obviously, the situation is going to determine how long you're going to go into that interview of medical history and complaints and all of that. Something that is of life-threatening stature is going to include a lot less conversation and a lot more doing. Especially if the past medical history is irrelevant to what is taking place. Somebody with COPD and emphysema, that issue is going to come into play, but it's not going to be nearly as important as somebody has bilateral open femur fractures. Right? You've got to deal with the situation on it. Acadian, they're still around. So, for documentation, record date and time of physical exam. All that stuff should be done in your PCR. Determine the patient's age, sex, race, birthplace. I don't know why birthplace is important, but it is. Occupation. That's important if there is certain illnesses going on. Less important now because OSHA is a thing, but back in the day, again, making this reference, people dealing with working in foundries and mills and mines and all of that with respiratory issues, knowing that they did those things was pretty pertinent to treatment just because we had to know what they were exposed to. But again, with OSHA and all that stuff being involved, those exposure are limited on an employer level. Patient's chief complaints are typically going to do with pain, discomfort, or dysfunction that cause the patients to request help. Again, that's going to be one of those things that you need to focus on. We'll deal with a lot of people who have a lot of complaints or ailments. Asking them if you had to pick one thing, what is bothering you the most, gives you an idea of what to start on. Doesn't mean that's the only thing that you focus on, but that's where you need to start. We should all know what OPQRST, and then they've added ASPN on there. The AS is associated symptoms, and your PN is pertinent negatives. Pertinent negatives are a very big thing for us. We deal with that probably just as much as we rely on what the patient's complaints and signs and symptoms are, just to rule out or to treat or not treat due to certain things. So knowing, you should already know the OPQRST, but knowing those extra two acronyms will be on your test. Onset, we should know when did it start. I'm not going to go through all of these in detail. When do you develop it, and is this a acute issue or a chronic issue? That should be what your onset fixates to. Provocation, does anything make this better or worse? So it's a big one with chest pain that we can eliminate certain things with, or attempt to eliminate certain things with. The old adage is if they have chest pain and they move or something, do something a certain way, and it does make it worse, then it's not cardiac related. That's not entirely true. It's a good way to start. You can now think that it's muscle, pleurisy, lung, something to that effect, but just because they raise an arm and their chest pain gets worse does not completely rule out cardiac in nature. But it's a good, rule out or something like that. But asking what makes it better or worse, or does anything make it better? If you take a deep breath and hold it, does that make your breathing feel better, or whatever the case might be? That might lead you to believe, hey, maybe they need some positive pressure or something to that effect. So asking those questions is beneficial to not only you, but the patient. Quality, how does the patient perceive this? They tell them to explain how it feels. What's an example of that?
No.
Describe how it feels. Is it crushing? Is it sharp? Does it burn? Before you give them those adjectives, try to get them to describe it themselves. But usually, we all know when people are in serious pain, like, describe your pain. It's painful. Thank you. So getting them to give you some sort of adjective can be beneficial of what it is. Region or radiation, where does it start and does it go anywhere else? Also known as referral. Referred pain, radiation, any of those things. Is it pain or tenderness? Meaning, like, is it always there, or is it one of those things like, I'm good unless I move, or I'm good unless you touch it? One of those things. That's the difference between pain and tenderness. Have them identify a specific location. My thing is take one finger and point to where it hurts the most. Half of the people will be like, it hurts right here. I need you to take one finger and touch one part. Tell me where it starts, and then tell me the furthest place of where your pain goes. Starts here, hurts to here. Perfect. Now I have a region to go in. And again, does the pain move? Does it radiate? Do you feel it anywhere else? Referred pain is felt in a part of the body away from the source. So, we all know in MIs, females typically present differently. They can have that retroperitoneal pain. They can have that shoulder pain, jaw pain, all of those things. Severity, 0 to 10, 1 to 10, 1 to 100, whatever scale you want to use. Obviously, the wider you make it, the less precise you're going to be. So if you want to do like 1 to 100, do like 63. That's a 6. Okay, so just narrow that down. And obviously, you have to put it in aspect to them. So, good question is, the worst pain you've ever felt in your life on a scale of 1 to 10, 10 being the worst pain you've ever felt, where are you at? But you have to take that into consideration. If they've always lived in a bubble and the worst thing they've done is stub their toe, right? But you'll see a lot of these people that have worked outside and done manual labor jobs all their lives and have 19 broken bones. They're like, it's a 3. Your bone, I can see your bone. It's a 3. You're still getting fentanyl, bro. So take that into consideration. Time. When do they begin? How long does it last? And is it constant or does it come and go? Those are big questions that you need to ask. Associated symptoms are symptoms that are commonly associated with that chief complaint. So what would be an associated symptom if the patient says, hey, I think I'm having an MI?
Nausea.
Nausea, vomiting, okay.
Shortness of breath.
Shortness of breath, chest pain would be the symptom.
Numbness.
Numbness or tingling sensation in their extremities. Diaphoresis, any of those things that will be commonly shown with this would be associated symptoms. So if somebody goes, hey, I think I'm having a heart attack. You got any pain? Nope. You got any difficulty breathing? No, I'm good. You got any pain anywhere else? Mm-mm. There's not a whole lot of associated symptoms, so we can use those to maybe rule it out. Then we go on to our pertinent negatives. Are any likely associated symptoms absent? That's what those would be. I don't have any of these, so either it's important, there's an issue that I don't have these because I'm looking at a STEMI on the monitor, or you're full of shit. That's how we use that. Don't completely base off an assessment or treatment based on associated symptoms and pertinent negatives because everybody presents it differently. The term normal is relative to that patient. What's normal for you may not be normal for me. Past medical history can help provide some insight or foresight into the patient's condition to go with your differential diagnosis and your field interpretation. How does the patient perceive his general state of health? Most people don't answer that honestly, but it's a good question to ask. Do they have any diseases as a child? Are there any family history diseases? And what pre-existing medical conditions do you have? I love that question because it never gets answered honestly. Do you have any prior medical history? Nope. What medication do you take? Cinepril, atorvastatin, metformin, Lipitor, Plavix. Oh, okay. No medical history though. Nah. Cool. Is the patient taking any medications? This is a big one too, over-the-counter medications. I don't know if it's in all of your areas, but here we have two like holistic places that people like fix themselves with ginseng and juniper. That's a big thing, and a lot of those things will interact with certain medications. So getting that over-the-counter medication is just as important in figuring out what their prescription medications are.
Are you familiar with kratom?
Who?
Kratom?
No. What's that?
I don't really know.
It's like a synthetic opioid. A lot of times, when I was working in a factory down in Bowling Green, we had a lot of kind of Eastern Island people who had immigrated.
It's not synthetic. It's from the plant.
I think that's the beetle nut.
It's a Schedule
Got
1 in
that.
Indiana, but it wasn't. And you can get it legally in some states, and it's used quite a bit.
Low doses, microdosing has stimulant effects. Large doses have opioid effects. Non-regulated by the FDA, I assume. So there's no really no way to know whether you're microdosing or macrodosing. That sounds fun.
You can pick it up at the gas station.
Different strains. It's called kratom. It's a brown powder. First time I've seen it, I charged
I'm
terrible.
getting captured.
Why are you just?
I have two friends that use it. They clean off everything.
Does it work?
Yeah, and then that just became a problem because they're not addressing the underlying problem.
So now they just like crate them?
Yeah.
Where?
One of the gas stations sells it.
Oh, that's definitely the one across from the TNT video then.
Well, they're not supposed to. It's a Schedule 1.
Though they also sell Delta 8 and 9 and everything else.
That's legal.
And Spice.
Can confirm. That is Schedule 1.
The Marathon just south of Santa Fe. The Haji Mart that's across from the
Oh,
TNT
yeah.
If you can bring the patient medications with you, some of these people are gonna, if they have it in those, Monday through Sunday things that are all spread out 19 times a day, there's no point bringing those unless you just want to play like who's Clue and just sit there and research everything. If they have the bottles, bring those. If they have a list, bring those. For some reason, people only have one list and they cannot reproduce it. So most people are like, you cannot have my list. You can take a picture of this list, but you may not possess it. I don't know why, but take a picture of it, bring what you can, document what you can. Do they have any allergies? Also important. One of the biggest things that is probably going to be outside your realm of questioning when we start getting through pharmacology is, do you have any allergies prior to administering a medication? Just because it becomes second nature that, the medications you can give now are limited, and most people aren't allergic to naturally occurring substances in your body like epi. That'd be a problem to have. Or, sugar. Most people aren't allergic to that, right? You start getting into these compound medications and synthetic medications or natural alterations of medications, and people can have some adverse effects. And understand there's a difference between allergies, adverse effects, and normal reactions to certain medications. Biggest thing to ask is if they do tell you you have the allergy, what type of reaction do you have? Oh, my toes itch. Okay, you're taking this anyway. Oh, my throat swells shut. All right, we're not going to give that to you. There's obviously a different degree of reactions to certain medications. One is a hypersensitivity, meaning it can cause a rash, an itch, or an unpleasant reaction, but it doesn't inhibit their bodily function. Those are just kind of a heed the warning type. You have a question?
It's just you're talking about being allergic to naturally occurring things in your body. Like my uncle has a sugar allergy. He cannot have sugar. He can't even have some artificial sweeteners.
Because of the process and bleach, I assume.
I don't know.
Yeah.
I was just trying to, like, if I were to give him the D10 or whatever,
You'd have a reaction.
would he have a reaction?
I don't know because it's usually when I've seen that, people are allergic to the preservation or the bleaching aspects of it, not so much the sugar. So I don't know. Only one way to find out. Give it an epi, I guess.
Can you have bananas?
Yeah, you can have like fructose.
So it's probably a compound of some like high fructose corn or whatever it might be. Does the patient have any mental illness? Have they ever been in an accident or hospitalized? And any surgeries? We should all know sample. I will tell you, my last class failed their skills days for months because they would leave out these two things, sample and OPQRST. We're going to intubate this patient. Fucker, we're not even there yet. Like that, they just were ALS, just fucking full send, right? Do not forget your BLS stuff. If you don't have your BLS down, you are going to struggle immensely in this class. You need to have a good foundation. You need to focus on your ALS or your BLS before your ALS. Going through your sample, working through your OPQRST might seem stupid to you, but that is where you need to focus. Medical history of immediate families may be important in certain situations. Obviously, that's kind of like a cardiovascular disease, diabetes, hypertension, certain things are hereditary. Obviously, if they have a broken ankle, that doesn't come hereditary. So again, kind of focus on what the ailment is. Find out what kind of life the patient needs. Tobacco, alcohol use, drug use. We know most people aren't forthcoming with the drug use aspect of things, and sometimes even the alcohol use. Typically, if they'll smoke, you'll smell it. Kind of like you're sitting in an ashtray with them, especially if they smoke a lot. And you know, how much you smoke? I only have 1 or 2 a day. Because you don't smell like you smoke once a day. So trying to get that truthful information can be important. The cage questionnaire. Ask about blackouts, accidents, injuries, and what happened. This is kind of one of those things that we can use or we get to see when people are under the influence of mind-altering substances ranging from alcohol to illicit drug use. Cut down, annoyed, guilty, and an eye-opener. They'll go through those different stages. Obviously, I think anybody that's probably worked in the same area for a number of years has probably ran on the same patient for some type of alcohol or substance abuse more than once. I know, most people, their eye-opening experience is death. They stay that way, so there's not a whole lot they can do. Some of those people, though, will experience death, and then we'll get them back, and some people are like, fuck it, I'm not doing that anymore. And then some people get that I'm invincible aspect of life, and then they die. But they can go through those different stages. Ask about normal food and drink and dietary intake. Especially in the summer, have you had anything to drink? I've had 6 Dr. Peppers. That's not good, right? You have to understand that there's a difference between good drink and bad drink, good food and bad food. Have you eaten 19 Snickers? You're dying. So that can also be important. Ask about immunizations for diseases if it seems pertinent. I know for a while there, a lot of the providers were mandated to ask if they had flu, COVID, and pneumonia vaccines. I feel like we've kind of, since Fauci's being drilled at Capitol Hill, we no longer care about COVID anymore.
So I talked to Aaron, and he was like, well, I need everything. You said, I said, I have, sir. I said, go back and check all your emails. I said, I'm looking at right now, 416. I sent all the pictures, all the information, spreadsheet, who's coming, all the data that you wanted. Well, it must have got lost. Let me go back and look. So, like, his zero communication with his up there. I sent everything.
Did you get a hold of them?
I did get a hold, and he was gonna get back to me. As far as orientation, I know you don't want to go to IU. Who will not want to go to. No.
10 people will.
Sounds good. And
Does the patient exercise regularly or lead sedentary existence? Here. That is going to go play into patient's health. Hazards at home. That's a big one that we forget on a lot of runs, especially with our substance abuse, our mental health and things like that. Do you feel safe at home, or do you have a safe network at home? That's one of those lines of questioning that we leave out that could actually make a big impact on their quality of care or what happens to them. Safety measures can be put in place. They're going to determine the extent of damage caused by a particular mechanism of injury. Ask about upbringing and home life. We all know about pre-exposure and predisposition. Religious beliefs only for treatment, not to try to convert them in the back of a truck. You believe in Judaism? No. You have a moment to talk about it. It's not what we're doing. More of, is there any type of, do you have any religious beliefs that will prevent you from doing my job in the fullest capacity? Like I said, the J-dubs would be like, I don't want blood, or whatever the case might be. There's different religions out there. I'm not a religion expert, so I'm not going to tell you I know what they are, so it's better just to ask the question. Review the body symptoms, patient's chief complaint, conditions, and how you determine their body system to be used. And you're going to constantly evaluate that. Patient's weight, recent changes. Have you had any dietary differences? Have you been eating as much, drinking as much? Have you lost a lot of weight or gained a lot of weight for no reason? Weakness, fatigue, fever, chills. Check their skin, hair, and nails if they have it. Check their head, eyes, ears, nose, and throat. Why are all those important? What are all of those? Mine is kind of the head, but it contains a bunch of them. Huh?
Mucous membrane.
Mucous membranes, correct. You don't know what the body symptoms are? There they are. A couple more. We need to go back through A and P and go through all those again.
Probably.
Write it all down. Clinical reasoning, conduct history and physical exam, arrive at a field diagnosis or impression. Here's the biggest thing that I can tell you from experience and watching providers grow. Make a fucking decision. Okay? And then have a game plan to go with it, both good and bad. I'm going to decide to do this. If it works, I'm going to continue to do this. If it doesn't, what is my way out? But sitting there going, I don't know what to do with my hands, is not treating your patient. This is the biggest area of make a decision and go with it. And you don't always, again, BLS before ALS, especially if you're on the fence about something. Let's start small and see if there's any micro improvements. Or maybe I think I'm gonna have to intubate this person, and I give them a breathing treatment and some Medrol, and I can breathe again. And you're like, I can intubate, right? Or you're dealing with an unresponsive patient. I should probably intubate them. Let's check a blood sugar. Before you swing for the fences, start small and work up, but always make a decision. Pull the trigger on something, but have a safety net. If this goes wrong, I have this. If this goes right, I know what I need to do. You need to make a decision. That's the biggest thing people struggle with, is just making a damn decision. Apply your clinical experience and decision making to develop and implement a management plan. The longer you do this, the more you'll see and the more influence and experience you'll have with certain medications and certain disease processes, and you can start bringing them together. Now, that doesn't mean it becomes cookie cutter because everyone's different. But if you can say, hey, the last 9 times I've had this particular STEMI, I've done these things 7 times and they worked. The other 2 died. Let's not do what we did on the other 2. Let's start somewhere solid and make some type of clinical experience and say, in my experience, this has worked in the past. Now, does that mean nothing else will work? No. But that means you have a good foundation for treatment. Knowledge of anatomy and physiology is huge. Again, tracing a drop of blood to you might seem minute, but I cannot tell you how important that is in treating patients. Organize information you obtain from and inform concepts from it. Elicit chief complaints and formulate differential field diagnosis, and that's the thing. You have to come up with a field diagnosis. The last thing you want to do is call North Downtown, be like, hey, I'm bringing you a report for a patient. Call a patient report. What do you got? Don't know. What do you mean? Yep, they're fucked. Haven't done a whole lot, and I don't know what to do. See you in 5. Like, go with something. You need to identify and deal with that medical ambiguity. Stuff is going to change. Not everything is always the same. Differentiate between relevant and irrelevant data or information. Recognize patterns. And explain your decision and construct logical arguments. And that's the thing that I tell my providers. We might differ on opinions. Just like if you bring an EKG to 5 cardiologists, you're going to have 6 different opinions. Because one of them's got to be more important than the other. Right? But if you can articulate why you did something and it makes sense, you're fine. There is no cookie cutter recipe to emergency medicine. We are in a constant field of dynamic changes. So as long as you can articulate, hey, I would have done this. Well, I did this because of X, Y, Z. I would have done this because A, B, C. Who's right? Potentially, you're both right. Or in national registry cases, one of us might be more correct, but we're both correct, right? So make a decision and just be able to articulate why you're doing something. Any questions? Any feedback, issues, concerns, comments from today at all? We're going to keep going. We're not leaving now.
I just had a question about the last part that we went over. Obviously, us saying that this is why we did something and the hospital does not agree with it. And you're like, I would do, okay. Just making sure.
My politically correct answer for you is not this, right? My politically correct answer is you say, what are my protocols? I don't know your protocols. Shut up. Just because you have to ask a doctor to fucking change a diaper does not mean that I have to. We operate in 2 different fields. Stay in your lane. Don't say that part, but that's how I tell them. But and I will say this, you are going to experience this, and we deal with that a lot here because we have some weird shit that people aren't used to seeing. And I will tell you, the first few months when we introduced ultrasound 1.5 years ago, rolling into U of L going positive fast, we've administered TXA because of XYZ. They went, excuse me, what? How the fuck do you know they've been positive fast? We did ultrasound. No, you didn't. What hospital are they from? They're not from a field. Then how do you have ultrasound? So I go, positive fast. They go, holy shit, okay. And then another doctor, 2 days later, they'll experience the same thing because it's a different doctor. But after a while, they stop giving you the shit. Now, there's some doctors that just either A, don't like doing their job because you brought them a train wreck. Not that you caused the train wreck, the patient's just a train wreck to begin with. And you either A, caused them to do their job, or B, took all their fun away. So now they got this critical patient, but they're intubated, they're on drips, they're on pressors, they're on fluids. Labs have been done and all this, and they go, what do? You watch them, call the fucking RT, put them on a vent, send them up. So you're going to have a different reaction from different people.
I said can confirm.
And then in your case, you call me in on it. But yeah, I mean, a good doctor, a good medical director, a good somebody, if there is a true issue, should pull you aside and go, hey, explain to me your reason. And then you're going to explain your reason. And then they're going to go, okay, I see where you're coming from. Consider this next time. Or they go, you're an idiot because you didn't consider X, Y, Z. And they have that ability to tell you you're an idiot because they need to do it professionally. That's how we grow. That's how we learn. We don't have the ability to perform on live patients and then just go Alt F4 and reset, right? Our learning is on live humans, sometimes dead, but that's how we learn. Any other questions? No? I don't feel like you're very interactive today. We should do some calisthenics to get our juices flowing.
Answer the whole question.
Look at you. Okay.
Also, Heather, are you gonna use the second half of OP-QRST, like the ASPN? Are we using that like in our scenarios?
It would be good to, yeah.
Okay.
Now, you don't have, now, and that's a decent question. So, we're not gonna go, what are your associated symptoms? Because they're gonna be like, huh? Associated with what? Well, you should know what happens if you're having an MI. The fuck I do, that's why I called you. So, that's not something that you're gonna go through and be like, you have associated symptoms with pertinent negatives. That's gonna be something you'll articulate and be like, in my differential, because obviously you're gonna be going through your primary assessment, right? You would say, based on these things, based on my OPQ-RST, I have these associated symptoms, and or I have these pertinent negatives, I believe it's this, or because of these pertinent negatives, I don't believe it's this right now, so I'm going to explore this.
Okay, so verbally you'd say that in a scenario?
Yes.
Because I know the ASPN, I typically put it in reports, and that's where I would see it, is documentation rather than verbal or, and I guess some form of.
So while you're doing scenarios in here, you're going to want to verbalize that, so we know where we're going and we know where to head. Because if you don't go, I'm associating this with an associated symptom, and you're just like, this, but you don't articulate why, we might go, holy shit, because it could be wrong.
Yeah.
But because you see these things, you think it's right, we can go, all right, here's where we fucked up.
Sure.
This, right, yes. Like me, I can do math in my head, but I still have to write it all out in class, right? It's stupid, but if I did screw up, you're like, there it is. So it is a show your work thing, especially with the pertinent negatives, because you're not gonna ask a patient, you have any pertinent negatives? Who's pertinent? I want to see some math. Like that's, you're not gonna get a response. Anything else? Okay. Good. We'll take a few seconds and go stretch your legs. We're gonna go into chapter 2.
Can you grab one of the?
Dispatch, you show medic 1, clear and en route.
Ish, how are you gonna do your clinicals? Cause don't you guys work 5/8? Cause I'm stressing over my.
we're doing 5 on, 4 off. July 1st. But how am I gonna do it? A lot of them is hit stop water.
Well, hey,
I'm paying for the sins of my past. Huh?
so I should have gone to college when I had a chance.
Oh no, I went there. I got a degree in safety, but I'm a cop, so I'm still an idiot. But I'm 2014, I took paramedic class. In the paramedic, I got hired on PD, and I was 21, and I thought that was,
Yeah.
the shit, and it was not. I was wrong. And $8,500 later, here I go.
Where? Outside of my bed.
Facebook needs to take away Facebook. Yeah, I spend way too much fucking money on Facebook. It's worse than TikTok, but this, or Temu also has me on the ball. I love
I feel
Temu.
like that's worse than buying from Wish.
No, Temu is so much better than Wish. You actually get it on time, and it's the actual product you use. You know, Wish.com, you order things, and a year later you get it, and you already forgot what you used.
Still made my kids look right.
I mean, I'm sure that slave in Thailand is doing a great job.
You have a computer to get your.
You, so you go and you apply for reciprocity.
Gotcha.
And then you have to pay the money, and then you have to take a 2-hour long pronunciation of death class and a
Isn't the kids one?
yes. And then they issue
Yeah, how much?
$250. Yeah.
$250.
Yeah, but if you're in Kentucky, it's like 10 fucking bucks. You live anywhere else, they're like, "Ah, fuck you." Hey, you. Oh, sit here having a blast. Are you gonna bring in the worst Girl Scout cookie that you do? Look, who woke up one day and was like, let's mix toothpaste and chocolate,
Thank
and
you.
people will come.
First off,
Mint chocolate chip.
first off, the United States is the only country that uses mint toothpaste. Other countries use.
Also wrong.
Depending where you are.
Which is also wrong.
Depending where you are in
Fucking
the country,
toothpaste.
they call it.
Spearmint's not any better though. I want to
tried
brush
it.
my teeth with fucking surgery. You're not
Strawberry, the common
I use
flavor in other countries. So
raspberry, I have a fucking drink, and
I'm gonna have to. Submit.
The mint chocolate chip. Dog. That's so good. I'm pretty sure I'd rather try to punch butthole than eat anything in chocolate chip. Only bro made me that. Some popular opinion, but only bro made me that. I'll choose it. Hey,
If you only knew.
just like what my dad said, if too late, she ain't a lady. You better-
You know what?
Ain't too late and she ain't late.
Big girls are like mopeds, they're really fun to you, but
I'm
it's
gonna
around.
be fucking Friday. Tomorrow I'm gonna be. Much time and. 20 hours to, you know. Yeah.
Rob, already been kicked
See you
out.
there.
Yeah, girl.
You said we got. I haven't been kicked
Yeah. Yeah, this one on Fridays. This clinical?
Yeah, what happened?
Yeah, we have lab days on Fridays
Mhm.
for clinical one.
Oh, no, I'm talking about like our actual clinical students. Do we got lab in it?
We have 1 hour left.
Yeah.
Or? Yeah, lab.
Yeah, I just fucked up and planned on to lab Friday. I didn't. Yeah. I'm just not involved over here with all this shit. I did, at Walmart.
If you don't know how to cook fried chicken and potatoes, I'll.
It's just so bad. You're not, you just go down and evaluate it. Yes.
Remind me, I'll tell you what.
I need to see.
No, I was working on it. I was returning.
Did you kind of do it right now? The one areas I got to work in, she worked. And,
This is great, right?
I didn't do it. So I have.
We need another fucking.
It's good to know it's not Tuesday, or Friday, even though.
So, I would tell you, I made the correlation.
Oh, yeah.
That's what I'm talking about.
I want to sign up for it.
Yeah, I thought it was
Actually, no.
Correlation.
Wow. My very good. We haven't talked.
I don't think that would be.
I don't think that would
Like the next time. We all hear about shit that recognition. Well, Tina, she was just out there recognition, I think, walk up to the
Yeah, if we have.
like trash.
So. That, it was a lady. Yeah, it was like. I actually know.
I'm out of town.
That's one.
Oh, I've already figured out
Trying
that
to see if I can.
August babysitting is gonna cost
We worked till
$400.
I don't know, I know a lot of people.
And that doesn't even include my lab days. I don't know what hours.
Let's spill the name, I'm curious.
I just need to go to Jacob, like I need you to take it.
Just start in a daycare at work.
Oh, well.
We have to talk about last language, start one of them.
We brought it up too.
Right.
We also have that day.
There's a 24-hour daycare in Dayton.
You're like.
Oh, he's doing the
Going
same
on.
with me. It's fucking great.
How many of you are gonna actually go to IU?
I'm gonna try.
No, I'm not asking to try. How many of you are definitely going to go to IU?
If there are weekend time though, because I can only go on
SCR.
So you're gonna only do your entire clinicals on the weekend?
any day I go during the week. I just schedule PTO for it, but I'm maximizing weekends. And there's some places where, like lab one, I could only do it during the week, so I just schedule PTO.
It's, I'm going to tell you, it's mathematically impossible the further we get into this.
Oh, the further we get into it, I will just deal with it. And I have a lot of PTO banks too, and some flexibility.
I'm just letting you know, it's mathematically impossible when something's clinical to utilize only weekends.
And at some point, I'll go back. I'll just go to 2 days a week. Don't have to.
So,
Yeah, that's gonna happen.
yeah, how much is it?
Yeah.
Well, it's important. Why do we, or anything else that it could be? All right, maybe, so we know what it is, just text me.
I thought that day we could reach out to him before.
So how many of you are in fact going to go? Which clinical line? That means all of you, I will see your name without you at some point.
This is Methodist, right? Methodist,
It depends on who's got opening, it's not just Methodist, it's all about you.
all the way. Even better.
That's what I was talking about.
So you're going,
Can't love this today.
okay, here's the thing. So the date right now is July 8th. It's at 10 a.m. So we're going to meet here. Either going as a collective group by yourselves or Scott Boswell potentially, maybe, I don't know, will be going with you to company. I cannot go. I'll be potentially out of state. It's at 10 a.m. He said it takes 2 hours. And he said this is the only day that he can do it. This is the earliest, I should say, that he can do it.
I guess, can you cancel my Norton Women and Children's ER time for that day? Because right now I'm set to go to.
So you want to cancel your,
If it means that I can go back to the IU, yeah.
okay,
I'll just take.
you'll have to set a request to cancel. Oh, no, I'm not canceling you. You're not, no. One? No?
Yeah, cause that means that's showing me to do. so
You three are,
I don't think it'll work good. Good repair.
Sean, are you want to go?
Like, is it Bloomington?
I know, I was just.
No, this is IU up in Indianapolis. Yeah, there's
I'm scheduled for your time.
I know it's the last second. I had heard from this guy back in May. Well, everybody's scheduling shit already. But he never responded back to my emails until, and he tried to contemplate that I'm busy, I'm so sorry, I'm this bullshit, and it didn't work. So you don't want to go. I know you do.
Yeah, I mean, I've already got clinical once.
I'm trying to get everything checked.
Okay, so you don't want to go to IU either? Out. I will update him and let him know that. All right, sorry about that.
Primary assessment. This is something, how many of you do not work in an EMT capacity full time? So, everybody else should be doing this every day, right? This is not something that I should have to drive home, spend 2 hours on, however, if I need to, we will. But with that being said, you are going to have a lot more deductive reasoning and critical thinking skills involved in your primary assessment. Obviously, nothing changes for us as we identify and correct immediately life-threatening injuries. It could be your ABCs. That does not change for us. Any airway compromise, lack of breathing or insufficient breathing, or circulation problems, we address before anything. This is BLS before ALS. Now, that doesn't mean that we can't induce some ALS procedures when correcting these things. However, we still need to recognize them from a BLS standpoint. Following the primary assessment, decide priority regarding transport or on-scene assessment and care. You're going to follow your protocol on that, but we don't, and I'm going to say this, we don't know because the state doesn't know what they're going to do yet. National Registry has eliminated all psychomotor skills for paramedic class after July 1st. So that means you won't have them. However, the state has the ability to say, hey, we're going to do this, or we're not going to do this. As of 2 weeks ago, it looked like they were going to do 3 skill stations. That could change to 0, that could change back to 7. They don't know yet, so I can't tell you what they're going to do. But as of a couple weeks ago, it's just going to be out of hospital, 20-minute out of hospital, which I agree with. A mega code, I agree with, and then a oral. But those are, as of right now, those are the only skills that are slated to be done. But again, that could change. Huh? It's 2 rhythm strips that they give you that they say, what is this? How would you treat? And then it's a scenario-based question that you just verbally treat.
Is that for Indiana?
It's class.
So you're the one that signs off on that. We don't have to go somewhere and do it.
Not if the state induces it. Now, you won't have to go anywhere because that's part of your class that we'll put site on here. So like, you'll have to come here to do it, but you're not gonna have to, if you choose not to, you won't have to travel to Mississippi or Ohio or any of those. We'll do it here. Proceed systematically through your ABCs. This does not change. You form a general impression. You consider C-spine stabilization. You get your alert and oriented status. You assess and manage the airway if it's life-threatening. You assess and manage breathing if it's life-threatening. And you assess and manage circulation if it's life-threatening. Then you will determine, and if there's a culmination of those things, you will determine the priorities in which those need addressed. We should all know our general impression is our first thought of what's going on with the patient. And I will say, just because you form a general impression, please don't just stay on that rabbit hole and get tunnel vision. If you get information along the way that says, hey, this isn't really fitting my narrative, you need to adjust your impression. Don't fit their illness or injury to fit your narrative. Determine clinical status and priority for immediate transport. What environment are you or they in? How critical is their injury or illness? How do they look? How are they presenting to you? What their chief complaint is, and just follow your gut. The patient looks dead. Check their responsiveness and breathing. Thank you. Feel for a pulse. You did know if they're pulseless and apneic, we start CPR. If the patient shows signs of life, conduct the standard ABC assessment. When you're doing these things, please take in your patient's age, gender, and their race that could influence how they're presenting or your index of suspicion. Determine whether or not it's a trauma or medical issue. And just because it's trauma doesn't mean that it didn't start medical. And just because of a medical doesn't mean that it's from some sort of trauma. You have to figure out if it's one and or both, chicken or the egg. I can't tell you, I mean, there's been a lot of car wrecks that I've come on. Been dealing with the trauma of a car wreck, while also having to address the medical issue that caused the car wreck. So not only am I dealing with the STEMI, I'm dealing with the STEMI with bilateral femur fracture. That limits my ability to treat that STEMI while treat these bilateral femur fractures. Just because you have this gory trauma, that's why I hate trauma. Because a monkey can treat trauma. Bro, fix it, right? And it's just there for you. Trauma is distracting to a lot of people. They hyperfixate on I see bone, and we don't even do a 12 lead. We don't even assess their circulation, their heart, their lungs, or any of that. The leg is split. They are dead because we just hyperfixate and get tunnel vision. The more serious the condition, the quieter the patient will be. Some of those people that are screaming, I can't breathe. You're screaming, you're breathing, right? But those people that aren't saying a whole lot, that are just sitting there lethargic, those are the patients to be concerned about. Look, listen, and do not smell your environment. Probably not listening. The other clues as you enter the scene, look around the home, look around the situation, look around the area. You're in a car wreck and we see a bunch of empty alcohol bottles in the front or back seat. You know, do we walk in and there's illicit drugs around the home? What might it be? Use your precautions. If the patient is alert, identify yourself and establish rapport. Reassure the patient, listen to them, and do not trivialize their complaints. If there's significant mechanism of injury, or you have an unresponsive patient, you need to stabilize the patient's head or neck. Patient's awake, explain what you're doing, ask them not to move their neck. We believe that this is trauma in nature. If you have smaller framed adults or children, you might have to use a towel to pad underneath their shoulders so you don't hyperextend their cervical spine. Never maintain C-spine. Picture of how you're little Billy there. Having a baseline mental status is crucial in anything, I feel like, because you need to know where you started versus your treatment and where you're ending. But it's very important in your head injury patients and your medical situations that can cause altered level responses. Diabetics, strokes, neuroinfections, things like that. We should all know what AVPU is, but if you don't, it's right there. It's probably on a page in your book as well. Alert, they open their eyes, they're oriented, the person, place, time, and situation. Organize coherent questions that they can answer. The quiet children are usually seriously ill or injured or ill. I don't completely agree with that, especially in today's society where everybody protects their children from air, let alone other people. That when a stranger walks up, they're not gonna be like, hey, how are you? What's your name? Like they're just like, and they grab around to the parent. I don't necessarily agree with that, but children are difficult to assess anyway. So that is alert. Verbal is those people that are nodding off or not interacting with the conversation till you talk or make loud noises that'll allow them to respond by opening their eyes, interacting with you, but if they're not engaging in conversation, they obviously doze off or go out. Pain is that tactile stimuli, that sternum rub, that pinching of the nail in a pen, the nail bed in the pen, or toe bed in the pen, any of those things. Please remember, decorticate or decervate posturing is non-purposeful and may be indicative of serious brain injury. It's very important. Unresponsive, they don't respond to anything.
What's the difference in those two? Does it mean two different things?
What?
They posture and sort
Typically, it can mean different parts of the brain are involved. Decorticate is worse, for sure. That's usually a brainstem herniation, deviation from midline, or induced in the pons medulla or brainstem injury. Airway assessment, if they're responsive, can they speak clearly and assume a patient airway is patent? In here, when you're doing your scenarios, that is something you need to articulate when you're interacting, when you're assessing. You don't have to go, let me see your airway. If you walk in and start this how you do and say, hey, how are you doing today? Great, I'm fine. That's something you need to be like, I have assessed their airway because it is open and patent. If they're having a conversation with me without any obstruction or difficulty. That is something you need to annotate. If the patient is unconscious, their airway may be obstructed. Assume unconscious patient has no gag reflex and cannot protect their airway. Suctioning may be needed to clear the secretions. If it's a cervical spine injury, open using a jaw thrust without head extension. We should know all that. For all of the patients, head tilt, chin lift. Everybody knows how to do those two maneuvers, correct? Okay. Listen for noisy airways that will be indicative of a partial obstruction. Gurgling indicates fluid blocking the upper airway, right at the epiglottis of the molecular area. That is a high risk for aspiration. Stridor is caused by upper airway obstruction. If you have a foreign body obstruction, you can attempt the abdominal thrusts to dislodge it. So all of you, to some extent in here, can do positive pressure with CPAP right now. A lot of you, I assume, don't use vents to do your CPAP. For those of you that can, I assume you use those Pulmodine or rescue circuits that just plug into an O2 tree. You guys use vents?
We use vents.
Good for you.
Well, we have vents. I've trained on it one time.
I would assume most places don't utilize it. What vents do you guys have? They're easy to use though. They're good, man. Huh?
I said bigger than we do here, we get to the
Okay.
CPAP.
But yeah, I would assume most of you aren't using full-fledged ventilators to do CPAP. You're using those positive pressure airway masks that screw into the Christmas tree, and you can set the peak by the dial on the mask. It is an effective way to do it. You can't monitor anything. You can set and hope your peak is there, and you can listen to the farting noises that they typically make on those, just because they're so strong. But they are effective, and they do in fact provide positive pressure. Something that you're not familiar with is bi-level positive pressure. It's the same thing as CPAP, but different, meaning that you have two different pressures on inhalation versus exhalation. So you would have a inhalation pressure and an exhaling pressure that allows their lungs to keep and maintain peak, but at different levels, where continuous pressure is just literally sitting in front of the fan, essentially. Where BiPAP is like one of those oscillating fans where it gets stronger and then it goes away and it gets stronger and goes away. That's what BiPAP will be. Obviously, you'll have the ability to do intubation. Where you're located in your service is going to dictate whether you can do RSI, nasal, DAI, or any of those. Then you have surgical or needle crikes. Those will be new to all of you, hopefully. If you've done one, don't mention it so you don't get your numbers pulled. Carry on from that. Surgical crike is going to be you using a scalpel and making incisions along the cricoid cartilage, where a needle crike is finding that landmark, inserting a metal needle into there, and then using a BAM or reducer to connect high pressure oxygen to the needle. But you have to remember, you're using about a 12 to 10 gauge needle, and that's what's providing oxygen, so you're very limited on the restrictions. So pressure is huge in that aspect. Those last two, the crike for sure, it's only if the airway becomes totally obstructed and you cannot get that clear. We don't crike people just because it sounds fun. So I can tell you from experience, it is in fact lots of blood.
You have the quick crike kit. I've never seen a user open it up, but is that just helping set a landmark, or is
The
that?
quick crike kit is a really big needle. It's like a 0 gauge needle that you put on there, you line it up, and then you slide this thing, pushes a needle through. The good thing about those is you can use those as a landmark where you can remove that guide. It's big enough that you can stick a bougie in, remove the guide, and stick an ET tube in. But that's not recommended because you can't see the vocal cords, and you could just be in there. It's fucking the vocal cords. So it's not recommended to do that.
When you say BAM, are you talking about that little red thing?
No, that's an old way of testing the tube placement. That if you get a whistle,
Yeah,
you're good. These are barometric assist something that they actually pressure. They take the concentrations of oxygen, they limit the concentrations, but they increase the pressure. So because you got to remember, you're trying to oxygenate food. Yeah. We got a crate kit back here somewhere. They've got one. I'll see if I can look for it. Something to consider are respiratory burns. If the nose and mouth are singed, the inner airway is probably singed as well. And then you have, with that, you have very limited time to intubate if you have respiratory burns. That is one that you just full send, like you address that now. If there's any type of thermal heat or radiation burns that are going on, that airway swells very quickly. Once you do intubations and you miss an intubation and you go back on that patient, you will see how much that airway swells just in your miss and your time being in there. Your airway does not do well to severe changes in the environment, and that is its reaction, whether it's cold or hot. But hot, it recognizes a lot worse. So that is something you need to address instantly, or you will in fact be striking someone. And that is a shit your pants moment for sure, because you get set up to intubate and you go in there and you literally can only get your laryngoscope halfway in and you read resistance. And at that point, you realize I have one option.
That actually sounds horrible.
It is.
That's
It was.
fucking terrible.
Anaphylaxis, vasoconstrictor medications to decrease upper airway swelling. What do we use primarily for that now? What do we use primarily for when we're paramedic? Also epi. Again, we do the same thing, just a little bit different, right? Wheezing, constricted bronchioles, smaller lower airway. We're looking for bronchodilators. What are those? If a patient is not moving air, he or she is in respiratory arrest. What are you giggling about over there? What's so funny?
He looked at me, I was like, is that not right? Confused.
Look less happy. There you go. Immediately provide ventilation with a BVM and high concentrations of oxygen. I feel like that's something a lot of people fail on, us here as well. When you're in the moment, you got the BVM out, you're getting set up for all this, but what are we not doing?
Breathing.
We're not connecting to oxygen. And we go down and we're like, oh shit, this is fun. Not that room air is better than no air, for sure. That's the thing. Like moving in and air out is better than not. But if you have the ability to administer some of that free radical oxygen, it will help you during the movement of blood and the intubation time. One thing we do here is passive oxygenation. So if we know we're going to RSI, we set them up on a nasal cannula as well as a BVM. That way they get constant passive oxygenation through their nose. So if we do have a failed attempt or there's a prolonged attempt, they're still getting oxygenated passively. If a patient is unconscious and lacks a gag reflex, insert an OP. If they have a gag reflex, we do an NP. And there's no facial trauma. That's what you do if you're not moving air. Here's where an OP should land. NP should land. Besides, you guys still nasally intubate them.
They're going away from it. Like as soon as ours expire, we're not putting any more on.
Good.
Just
That's barbaric. If the patient has no gag reflex and cannot protect their airway, use advanced techniques to maintain it. Obviously, we've got a wide spread of tools at our hands over what you currently have. Right now, you're probably isolated to that King or that Combi or that iGel or that AirQ or whatever, a supraglottic airway, right? Now, just because we can intubate doesn't mean that we just no longer have a use for supraglottic airways. You don't have to be too proud to get in there and go, I can't get this and I need something now. I'm dropping some type of supraglottic airway. That is still a thing. Using a multi-lumen King or Combi or whatever of those, using your iGel, which I'm not a fan of iGels, but again, your miles may vary, or the Air IQs, or an LMA, whatever your service uses. Don't be too proud to still use those if you have to. I will tell you, it is very difficult to intubate after you use that, just because of all the trauma that it caused from being down in there, being secured, and then it's always the guy with the worst balance is up there bagging, and every time they bag, they reach forward and lunge it into their throat. So then you're going there to intubate, it looks like, yeah, that old donkey show going on down in there. What?
Is it true that you can intubate through an iGel?
Yes, it is.
In the air queue, you can.
So that's the good thing that a lot of people will tell you if a supraglottic airway is placed, don't remove it. I personally, not what I'm teaching you, I personally don't agree with that methodology. Because if ET innovation wasn't better, it wouldn't exist. Because I will tell you, supraglottic airways, none of them, 0 of them, fully protect the airway like an ET does. iGel sure as shit don't, because everybody's morphology is different, right? Air IQ is the same way. The Kings, they share a tube, like all the tubes in the combies come to one tube at one point, and if they vomit, guess what it does? It goes up the tube and it comes back down both. So it's still gonna get in there. So through the Air IQs and the eye gels, you can drop a bougie. If you secure it well enough, then there's only one way for it to go, because the tip of the eye gel and the Air IQ are gonna do what? Include what? The esophagus, if it's in there correctly. So when you drop a bougie down, it only has one way to go. But I am a firm believer of at least taking a look to see if you can get a ET tube in. And if you go in there and you can't, just drop the supraglottic back in. There's no extreme technique to dropping a supraglottic airway. We all know that. So. Does anybody still use Kings or combis?
We have them on our trucks, but they're just ones that we have to do both air cues.
Yeah, we've switched to the air cues here. I think we've used 2 of them, I think, so far. But I figured the multi-lumen stuff has gone away just because then you have to have a 60 cc or 50 cc or 100 cc syringe and all that stuff. And just more moving parts. I didn't know if anybody still used it.
Some fire departments still got them.
Huh?
Some fire departments still got them.
Really? Well, I mean, they probably get the hand-me-downs when they got them and they haven't expired. Like,
So they still use combi.
I think that's more of a culture thing. Huh? It's more of a culture thing. That's what we learned 27 years ago, so it's what we know. And there's nothing wrong with that. You need to use what you're comfortable with, but it also takes a lot more time to use it. Altered mental status, confusion, apprehension, or agitation. Those can all be need to be considered during a breathing assessment. Shortness of breath while speaking, retractions, specifically in those 3 locations. Asymmetrical chest wall movement, meaning what? You have that flail chest or that seesawing motion, right? An accessory muscle use. You get those people in the tripod position with those perched lips, or they're hunched over, or they're trying to create peak themselves, and you see those retractions at their clavicles or within their intercostals. Those are all bad signs that you need to address something now. Obviously, cyanosis, flu is not good, right? Audible sounds, you should not, I mean, even though some of you are probably mouth breathers, I should not be able to hear you breathing. Any abnormal rate or quality to that breathing, it's not normal. And then you have nasal flaring as well. Assess the rate and the quality. Again, just if their respiratory rate's 16, but they're shallow or they're super deep, I would not consider that normal. There's your respiratory rates for cheer in that most of us don't know. I would mark that page in your book. It is page what, Jacqueline?
28.
Huh?
28.
28? Got 28. Note respiratory pattern. Tachypnic, hyperthypnic, or hyperpenic. All of those are terms that we can use. Cheyenne Stokes, where do we usually see that?
DK?
Strokes. You can use it, typically we see it during DKA. Any type of head trauma, neurotrauma, you can see it as well. You can see that as well too.
Okay.
That's usually, so there's a difference between DKA and your high glucose people. When you see them at 400, 500, 600 range, you'll see that where you have that. Your Kushmals is like your fucking 1400s. Biots, that's also can be referred to as ataxic breathing. It's irregular rate, irregular depth. They're usually gasping, may signify a brain injury, becoming hypoxic, or apneic is usually where you see that. Usually when we all get cold, toned out to a code, we hear they've got agnal respirations. That's usually what they're referring to as that biots or ataxic breathing. Some patients with acute pulmonary edema can benefit from CPAP. Again, you guys can do that now. The benefit to, which I guess you two are excluded, the benefit is if you'll kind of have a lot better understanding of vent theory, because I would assume that they didn't spend a whole lot of time with vent theory with you guys during CPAP. Put it on these settings and set it, forget it type deal. You'll have a lot more ability to play in the kitchen with those settings and understand what's going on the CPAP and BiPAP level. Assess the neck and chest before moving on to circulation. Again, make sure there is not that asymmetrical movement. Make sure there is chest rise and fall of some sort. And again, identify any life threats before moving on. Tension pneumos, immediately decompress the affected side with a large IV at the second intercostal or where?
Fifth intercostal, fifth and sixth intercostal space, just below the, above the sixth.
Between the fifth and sixth intercostal or the fourth and fifth rib center. Between fourth and fifth or fifth and sixth, and you ride what side of the rib? Top. Because all of the nerves and veins are on the bottom, so you ride the top of that top rib. And you do it where? Right in line with that armpit, right?
Mm-hmm.
For circulation, evaluate the pulse and skin. If there's any hemorrhaging, not bleeding, but hemorrhaging, address it. You go to the wrist and feel for a radial pulse. If a radial pulse is absent, you check for carotid. On infants, I go straight to a brachial or popliteal if I have to. If we have a radial pulse, it's a good indication that we at least have a systolic pressure of what? 90. And if we have a carotid pulse, it means that we have at least have a systolic pressure of what? 50 to 60. And if they don't have a pulse, biggest thing to learn today, start CPR. Assess the pulse rate and quality. There's your pulses for a cheer in. That's on page 30. Tachycardia fast, bradycardia slow. Note the quality and if it's regular or not. If there's any major bleeding, address it and stop it. Apply pressure, use gravity if that's what your protocols say, or apply a tourniquet. You can have major bleeding from not just trauma, but medical as well. Esophageal varices, stomach varices, stomach ulcers. You can have polyps. You can have, colon issues. All of those things. You can have internal hemorrhaging from your abdomen. You can have varicose veins. All of those things. Which varicose veins aren't going to produce a lot of blood. The varicose arteries can get some distance on. Internal bleeding is not easily controlled. And without, if they're firm and rigid and all that stuff, you can probably deduce that they've got some internal bleeding. But without some type of ultrasound, there's no way, or lab values, there's no way to totally confirm that there's internal bleeding. I will say when we're going to do pharmacology, I think in 3 weeks is when it starts, I believe. We will have to revisit pharmacology after we get past it. Because we are getting blood here, and I want to revisit that once we get it, but we're going to go through the stuff we need to know, and we'll take an hour or two for a day through somewhere else and work that blood factor back in. I don't have it worked in, and if there's time within there, then might have to visit that. Assess the skin, temperature, color, moisture. You have that mottled or blotchy, cyanotic, pale, ashen, moist, cool, warm, hot, dry, all of those things. Nice nails. Priority determination, serious injury or illness. Rapid head to toe. If any of those things are there, transport immediately. Good old CDC. Step 1, aimed at vital signs and level of consciousness. Step 2, look at the anatomy of injury. Step 3 is aimed at the mechanism. And step 4 is going to be all other findings. Any questions? Your primary assessment should take less than a minute. Unless you obviously have to address something. Any questions? No? You want to do IV stuff or do you want to do the next chapter? No.
Next chapter.
No.
I get the secondary assessment.
Very, very long. 300 pages.
I'm aware. That's why we're not leaving. Huh? $227 slides. I would say that most of these. Yeah.
Yeah.
So what we'll probably do then is we'll save patient monitoring for next week. We'll bump up your patient assessment in the field for next week. That'll probably take the first half of class. We'll start lab for the second half of class. The following week, we'll take your exam, and then we'll do lab that day, and we'll eliminate our project. How's that sound? You'll eliminate 628. Everybody good with that?
Yep. It's PTO, baby.
So tentatively, we are crossing off that project. I will tell you, following weeks of your assessment, if you dog shit, we will in fact keep that project. So it's up to you whether we actually keep that project.
Cash money and y'all can go to assessments, including myself, because I really like that Friday on. So put it in.
Why?
We don't have, that's the day we don't have. And if we don't
Ohio
have,
sucks.
yeah, I know, I don't want to go to Ohio.
Then don't.
I have to.
No, you don't. You don't have to either.
But if we don't have lab, I can leave earlier. So we didn't that.
You're still not working, so it doesn't.
I don't work that Friday. I do that Saturday.
You gonna be back Saturday?
Primary and secondary.
So now it's in field. Now that's the difference between lab day and Saturday.
Monitoring and in field. And then week 5, 6.5 from Monday and first half.
Really don't want to take down the training day for Friday, so.
Hmm?
I got a training day on that Friday, so.
Or you can come right here if you don't want to train.
Oh, we can ride at that time. We don't have to wait till.
Only have to wait until the 6th.
But we're only waiting because of the patient assessment. Next week is the 6th, correct? Is that correct?
I thought it was July 6th.
Right, but what I'm saying is.
You said it, you're the boss. I will be here to ride.
Hold on. I believe it started because it would not be completed with patient assessment until the 28th. So that means the following class would have been the 6th, correct?
Correct. No, the following class would have been the 6th.
There you
And then that Friday is when you have,
go. Okay.
when started.
Yeah, no, you can.
Yeah, you can bump it up on-
That would have helped with it.
Okay. Okay, time out. Then if you wanna, I will make you a deal here. If you want to keep that Friday, time out. If you wanna keep that Friday, we can come in Friday and go over what we would have on that Tuesday, because that's what's hanging you up.
Well, I don't want to screw her over, so I'll just.
No, don't,
She didn't plan to be here.
yeah, I already planned to be here, so it will be.
I like Fridays off. If I had an opportunity to get ride time knocked out, that's what I would choose.
Well, if we do that, that'll give you all an extra week for ride time.
I'm for it.
That'll give you ride time starting that Friday. Because that means you can start the 20,
Wait,
yeah.
We would just need to know what time so we can tell Billy what slots to fill for us to be here.
I mean, you're supposed to be here from 8 to 4 on that Friday anyway. That was already a scheduled lab day.
I just, like, on the syllabus, there's no, like, times.
Yeah, it says it at the top.
I feel like I covered myself.
most of
It
the
says
classes will be held each Thursday.
Supposed to say Tuesday. They both start with T's and stuff. We'll revisit that when we're done with this. Yellow mouth. Here it is. You have this chart on page. Okay. You're in chapter 7, I believe, right?
5.
Confused.
You just had 3 different chapters.
Secondary says chapter 5.
What? What?
I don't feel like this slide's gonna fall. Was that the phone? That's on 109. 77.
Well, there's a chart somewhere between 77 and 190 that tells you about width. This is a good thing to memorize. Dry and cracked lips are indicative of dehydration or wind. Swelling is indicative of allergic reactions or infection. Lesions are infection or some type of cancer. Them being pallor, good idea that they're anemic or in some sort of distributed shock. And then cyanosis is obviously cardiac or respiratory insufficiency. While I don't think you need to be a dental hygienist, if you find the need, it is a good idea to examine the oral mucosa for the color, any type of ulcers or anything like that, especially if you're containing or complaining of any type of difficulty breathing. They don't look the best. The presentation's not good because your mouth can has a lot of your tonsils and all of those things, your glandulars in there. That can pick up a lot of infection if you see any inflammation, any swelling, any white patches or something like that. It can be indicative of infection. What's the problem? We good? I thought there was a question. Okay. Know the color of the gums and teeth. Are they white, pink, red, black, purple, blue? Examine the buccal mucosa. Where's that? Cheeks. Inspect the tongue. Have the person say ah, and examine the soft palate and the punching bag. There's your mouth. There's your lips. That's on page 107. There's some gums in the lip if you've never seen one. You can get tattooed across there if you like it. There's the buccal. That's the tongue. That's the underneath of the tongue where you gleek from, right there. A hole. It's the punching bag. Note any odors from the patient's mouth. Look for any fluids or unusual matter. The neck, if you didn't know, contains your spinal cord, along with some vessels and conduits for the airway and food. Any major disruption can cause rapid deterioration or immediate death. You have roughly 8 to 10 seconds if a carotid artery or jugular is cut, like severed completely until you have imminent death. Sometimes if it's just somehow they just manage to include the trachea involved, you can sometimes control that, but they have very difficult breathing because they have no way to force it in. It's just kind of a leaky tire at that point. But you can in fact intubate through a severed trachea up front. It's no different than doing a crike, it's just a little bit more open. And then their esophagus, obviously for food. There's a diagram with the penciled in mustache. On page
111.
palpate trachea for midline, make sure it's midline and there's no deviation left or right. If it's deviated to the left, what do we have? If the trachea is deviated left, what is our first inclination to look at? On what side? Correct, opposite side. If it's deviated right, first thought process is tension on the left. Palpate carotid arteries one at a time. Never do a carotid massage, please. That's not a thing. Especially if they have AFib or they have history of some type of thrombo issue or PE issue, a plaque issue. All you're going to do is agitate that loose and cause it. Palpate the thyroid gland. I've never once in the history of 15 years have I done that. I have palpated lymph nodes though. If you feel swelling or like big knots, it's a good indication that they probably have some type of infection. That is on page. Milk it anteriorly. Don't do that. The neck is tender, swollen, or mobile nodes, inflammation from infection, hard or fixed nodes, malignancy, inspect and palpate for subcutaneous emphysema. What is that? What does that feel like? Anybody know?
Rice Krispies.
Rice Krispies, popcorn. It's a bunch of air underneath the skin in the free area that it should not be. That you have problem. People have problem if they have subcutaneous emphysema around their neck. Air is getting in there from somewhere that it shouldn't be.
I've had somebody who had it in their eyelid, and then it swelled their face, and went to the whole left side of their body.
Yeah.
So, their eyelid.
So either from some big trauma, or okay, or sometimes it can start as like an air emboli, pass through the membrane and then like grow, but that's very rare. Just because it has to grow somehow, so there has to be continued supply of air, or they have it leaking from somewhere else, and that's just where it picked. That was the loosest tissue that it picked up at. Not a fun time. There's a neck. You can check the carotid. You can check the thyroid, lymph nodes, chest and lungs. You have 12 pairs of ribs in case you didn't learn that in A&P. Respiration happens because the lungs diaphragm and intercostal muscles. That's on page something. That's how your lungs lie within your rib cage. The diaphragm underneath here, obviously. And then you have your other organs below it. When you're assessing these, it's imperative that they sit in somewhat of an upright position. They don't have to be a perfect 90 degrees, but I will say it is extremely more difficult to examine your patient when they're laying supine. Because gravity is taking effect and it's all melting out. It's a lot harder for them to inflate their lungs at that point because gravity is taking effect. So if you can have them at a semi-Fowler's to a Fowler's position, it's a lot easier to examine their breathing. Look for signs of acute respiratory distress. What are some of those signs?
Retractions. Retractions.
Okay. Okay. Cyanosis. Okay. That's a big one. Not breathing at all would be a pretty significant respiratory distress. Pursed lips, certain positioning, any type of frothy sputum that's coming out, retractions of their eyes or their cheek muscles, any of those things can be noted. Inspect intercostal space where retractions or bulging, palpate rib cage. One thing, if you're ever having, when you have those breathers that they're breathing really bad, they can't describe what's going on. Like, are you having trouble catching your breath, or does it feel like someone's sitting on your breath or on your chest, or can you not breathe deeply? Yes, the answer to yes is all of that. One of those things you can do is take your hands from the front or the back. It's easier from the back because you can apply more pressure. You'll be my guinea pig. Less sexual harassment, but you would not hurt it. And you can come under here and push in on their ribs and have them take a deep breath. If it feels the same, it's more of a restriction issue, because what you're doing is you're bringing in their rib cage and not allowing it to expand. So it's probably a restriction issue from them. If it makes it worse, then you're dealing with something internally that's probably some type of pneumonia or oxygen delivery or fluid issue. Just kind of as an assessment tool for you. Now, don't squeeze them where they can't move it at all, but apply some pressure so you can feel it rise, but see how it reacts to it. Listen to the chest for breath sounds and voice sounds. I don't care about voice, I would care about breath sounds though. Again, rails or light crackling or popping, non-musical. No Yanni's greatest hits in there. Wheezes or continuous high-pitched musical sounds similar to a whistle. There are some normal breath sounds and where you should hear them. That is on page 115. Ronchi, a continuous lower pitch sound and snoring quality. Stridor is similar to your wheezes, but instead of hearing them in the lungs, you'll hear it in the upper airway. It indicates either a partial obstruction of the larynx or trachea, or it can be done, like the obstruction can be due to swelling. It doesn't always have to be a foreign object. And then your pleural friction is that squeaking or grinding sound of the lining of the lungs and the chest wall. We know you can have no breath sounds in some areas or diminished breath sounds in some areas, and that's where we need to kind of gain our treatment from of what are we trying to address. Listen to the front and the posterior side systematically. Do it in the same order every time. Examine the anterior chest and the posterior chest, and obviously look for any type of deformity. I mean, if you want to get super cool, you can do all those things. Some of them are tapping, some of them are listening for certain things. Some of them are having them whisper while they breathe out to see if you can hear, if it makes the wheezing and stuff go away. I've not ever done that. I'm here to address the acute stuff and what's going to kill you, and I feel like if it changes while you're whispering and breathing out at the same time, we're probably okay. But again, you want to get real cool with it, feel free. Percuss the anterior chest. Again, you can listen for dead spots or collapsed lungs. Don't do this to frail old ladies, please, or frail old men either. Like, if you're going to do this, I do this regularly in traumas to see if I think that it is in fact like a pneumo or a tension pneumo or something. But if they're just complaining of shortness of breath or difficulty breathing, don't be sitting there playing the bongos on their chest. It hurts. Like it hurts. Don't believe it? Have your neighbor thump you on the chest. It's going to suck for Amanda because she's got Hulk over there. But the rest of you might be okay. But it is not a good feeling, especially if you catch a rib. Like, it hurts. I don't know if they still teach it. I know when I went through law enforcement academy, that's how we were taught to get people into our vehicles. Right here. Not in the throat. Right on that bone. They just push in their car. They probably don't teach it anymore because it's probably rude. But yeah. The little chest thump right on that bone. Right on the sternum. There's a good way to feel on the back and listen rather, go down in a systemic approach, and obviously you're gonna widen out the further down you go. You can percuss, as you can see, you can use your hand and hit your fingers, which is preferred. If you're having a hard time hearing, you can have someone do it for you, or you can wear, but it's very difficult to wear the stethoscope yourself while holding and hitting. So typically somebody has to do one or the other for you. But if you're in a noisy environment, like let's say the back of an ambulance, if you can't hear everything, you can use a stethoscope and move it away from the thumb, because if you put your stethoscope here and you're feeling here, what are you gonna hear? Your hand hit. So put it in the same side, left or right, away from where you're at, and thump it. If you hear that reverberation, it's a good idea that you've got something collapsed or full in there. Pattern for listening, again, same thing. The percussing the front, auscultating the front. Chest and lungs critical to assess child's respiratory system. I listen to child's necks, because what is the number one thing to become a problem in child's airway? Croup, their tongue, their throat, all of that is proportionally not the same. So their tongue or their airway can become compromised very easily. Typically, I don't listen to adult throats unless I think it's an anaphylaxis issue, but I always listen to kids' throats just to see if there's an issue there. It can be difficult to get children to take deep breaths, not just deep breath, follow commands. And a lot of the time they'll follow them but they don't know what you mean, like take a deep breath. They don't know what you're asking, so that can be difficult. Sometimes coaching them and showing them what you want them to do, just like, oh, okay. That chart's in your book. Tyler's? 14, 15, I don't know. 14, I get the bin, I can tell you. Bring it here, I'll tell you. Heart and electrical pump, obviously we know the heart moves blood. Cardiac output, again, you need to know these. Cardiac output is the amount of blood the heart ejects each minute. Stroke volume is the amount of blood in one heartbeat. And preload is the amount of blood that is returned to the heart from the body with each heartbeat. So what's coming back in to the where? Huh? The right atrium. The right atrium, thank you. Afterload, the term you need to know, is the resistance in the vessels that a heart must overcome to eject blood. Arterial pulse is each contraction of the heart. The E, not an F, correct? If the 10th is an E, it's a 14. Blood pressure measures the circulatory system, we know that. Venous pressure is much lower. And then we have our systolic and diastolic, which is systolic is what? Arterial pressure upon what? Contraction of the heart. And our diastolic is what? The artery during relaxation. Peripheral arterial system, oxygenated blood to the tissues, we know all that. Venous brings it back. Lymphatic system, we know drains fluid from the body tissues and delivers into the subclavian vein, plays an important role in the immune system. You okay over there? Assess arterial pulses, carotid pulses. What's Bruit's? Anybody know? It's a whooshing sound typically that you'll hear upon auscultation of the carotid arteries. It's turbulent blood, so that means that there's usually some sort of plaque buildup or deviation from. Know how to do all that. So again, I know we talked about this before, but you actually have 4 heart sounds. You have S1, S2, S3, and S4. S3 and 4 are a lot more difficult to hear. You can have an atrial gallop, which you'll hear on that S4, where it's like a flutter. I have never heard, I've heard like edema and stuff be measured in numbers, but I've never used pulses in a number of 0, 1 plus, 2 plus.
It was in our assessment.
Do what?
New chapel during the report, they used that scale.
Is there really? One thing that we fail to do regularly is compare pulses bilaterally, especially in chest pain and breathing patients. That's something we should do. I don't typically check femoral pulses on live patients. Get a little personal with people typically, and they don't usually welcome it. But it can be a good point that you have to, if there's obviously injury to that area, injury above that area, or during CPR, it's actually an easy way to do because you're not dealing with a BVM or a vent and vent tubing and a tube holder and mechanical compressions or on hand, like usually not a whole lot's going down on the distal part of the body, and it's easy to access and it's good return down.
Do you check it with your ultrasound?
Not typically during a code. We'll do it if there's been injury, like we'll use it as a Doppler for pulses and stuff, but we don't usually do it during codes if we can feel it. If we can't feel anything during, because we always confirm during mechanical CPR, so typically we can feel it. Do we still feel it when we shut it off? If there's not enough to feel femoral and carotid, they're both that 40, 50, 60 range, and if your systolic pressure is 40, you're not perfusing anyway, so we're going to start CPR. Yeah, popliteal, where's that? Dorsalis. Yep. I've never done a posterior tibial pulse. Observe for edema in the lower extremities, radial, brachial, femoral, popliteal, dorsalis, tibial. Check for edema. Pitting, again, that's done on a number scale of 1, 2, 3, 4, pitting edema, how much it hits and how long it takes. You shut that yet? That sucks. Wait till tomorrow. 1 plus is 1/4 inch or less. 2 plus is 1/4 to a half. 3 plus is 1/2 to 1 inch. 4 plus is more than 1 inch. And that's going to stay, it's not going to stay forever, but there's not going to be an immediate rebound. Does it give a time frame on the other slide? Bilateral edema is indicative of a circulatory problem. Unilateral edema is typically isolated to an issue within the structures of that extremity. Your abdomen, we know we got 4 quadrants. Once you get into the medic stuff, it'll break into 9. Ultimately, you have 4 quadrants, your right upper and lower, and your left upper and lower. Like I stated before, you need to know what organs are in those quadrants. Digestive system, I'm not going over. None of this I'm going over because we all went over it already, so we should know what it is, correct? What's ascites? Okay. Fluid in the abdomen, and pain upon palpation with fluid.
T-word.
Test. Timpani. Sound.
There's no studies that something to do with alcohol.
It can do with fluid retention. Female genitalia. Know what that does? Customary for female or for male clinicians to have a female partner present during the examination. There's very few scenarios in which we should examine anyone's genitalia unless there's like a katana through it or something. That's typically nothing life-threatening is going to immediately become from that. You got good aim and sever my penis off, I'm not going to bleed off from here to the hospital. It's not, your body's going to do what it needs to do to constrict. Same thing, very few injuries that are going to be done. Three scenarios I can think of are obviously childbirth. Gotta get there, gotta see what's going on, right? At that point, they probably don't care. Number two, if there's extreme vaginal hemorrhage, you need to see how much blood is coming out. And obviously apply pads to soak it, never pack it. We're not taxidermying it. Put it on the outside, apply some pressure, have them squeeze their legs, do all that stuff, or testicular torsions. Those are the three areas which I can see in that examination being warranted in that area. Yes. Not pleasant. Steve has felt my ball sack. In the kitchen. He was level with it. I in fact did have torsion. Not fun. Ask him about that. You got your butthole. We're not gonna go over that. We should know what it does or doesn't do. 206 bones. We're not gonna go over all of them. Please remember these type of joints. If you don't remember from A and P, highlight them in your book. Do any of your services in here allow you to reset joints?
I think we get one attempt. If there's no, if the vessel don't know, there's no probable injury.
You can if there's no pulses,
If there's no pulses, you get one.
but if not, you leave it alone. Anybody else? That's kind of that's a niche thing that you need to know what you're doing because you can cause more damage than good. I know here we get 2 attempts without pulses, 1 attempt if there is pulses. If it is of extreme discomfort that allows impeding patient care or patient comfort. Like, besides, like, it doesn't feel good, but if they're like flailing around and stuff, we will get one attempt to set it. But again, you have to be really concerning with vasculature.
United States, you can move it into a position.
Yep. Like shoulders, you move one way, hips, you move another, knees, you move one way. So you have to know how to, like, you don't just yank on it. That's bad. You have to know, like, usually you move it in the opposite motion, or range of motion. Like your shoulders, you'll bring your arm up, in, and then over, and typically sets back in if it's in the back. Opposite if you're out. These are all different because it depends on if there's, certain things involved. Yeah. If you have the ability to do that, you need to learn how stuff moves. Listen for crepitus, that's big. Okay. That's a finger. Knuckles, it's a wrist. No, don't touch me there. Come here. Hey. Hey. yours. Funny bone. I wish a bitch would. Over here. Go Hitler. He went that way. Now he went over there. Official meeting, defeat thing. Got it. So these are all getting into areas of each thing that we're not going to get into because we've already went over it in what you call it, A and B. This is on what page?
153.
153?
Yeah.
Okay. Know what those four things, know what normal, we should all know what normal is. Lordosis is the exaggerated lumbar concavity, so going in. Kyphosis is the hunchback. Scoliosis is when it looks like a chicane going vertically up the back. So this is like when people looks like they're trying to make their titties and their ass bigger and they walk like that. You have that huge sway in their back going in. Kyphosis is the hunchback, and then scoliosis is where it's vertically going like a snake. Again, we can palpate the spine when we do that, look for step-offs or anything of that. People will typically know if they have scoliosis where it's bad enough that they get treatment or have impending ailments from it. So if you're like, you normally look like there's a snake on your back, like you have scoliosis. Flexion is towards the chest, extension is towards the back. Rotation, we should know, left to right. Lateral bending is shoulder to shoulder. Bending over to the side, and neurological, we're going to assess the level of consciousness, basic orientation question. Some of these need to be beyond, what color is the grass in the summer and what color is the sky. Do you know where you're at? It's fine. That's a good basis one. Who's the president's okay, but a lot of these people can answer those disoriented. I know we like to mix in here. If I give you 4 quarters, a dime, and a nickel, how much money do you have? Like that, there'd be some cognitive thought. Mickey Mouse, a cat, or a dog. That one trips people up all the time, so it's really fun, and it's a good way for the dog. You're like, fuck yeah, you're going to hospital. And they're like, I don't need to go. But again, you need to ask questions beyond what's their name, what's their date of birth, what's like, a lot of those people can rattle that off on a drunken night. So you need to put some cognitive thought into the questions that you ask.
Some people don't know what day it is or who's president.
True.
They usually tell you that though, and you're like, that's
Mental status and speech. Again, cranial nerves you can examine if you learn the dermatomes. Motor systems, sensory systems, reflexes. Vinsky signs, taking something sharp and swiping up on the bottom of the feet. See if you get the toesies that spread out. You take a pen, put it on someone's fingernail and push into it. Not a pleasant feeling, but it's short term. Do they pull away from that? Is there any reaction at all? Reflexes, obviously. We know our cranial nerves. That's on page. It's really wise of you to restudy those. That is an awful picture. He signed off to let that be in the book. Muscle tone. These are definitions of certain muscle tones it would be wise to know. Spasticity, increased tone when passive movement is applied. Rigidity, placidity, and peritoneum. This is a good chart. That is on what page in your book?
161.
That's kind of a dermatome thing that shows what peripheral nerves control what and where they exit at. The reason it's good to know this is if you do ever have a spinal injury, right? And you're like, hey, I can't do this, and you can kind of either cut this out, memorize it, or whatever you can do, and say, hey, I can't move my whatever, right? You kind of know where the area of injury is at, whether it's a compression, a full, severment, or whatever the case might be. You'll know it's full severment, but if there's a compression or direct injury that's causing issues there, you'll have an idea of where it's at. Grade muscle, 0 to 5. 5 being active movement, 0 being none, and then filled in between. I know that some of us still catch patients' grip when we're doing stroke scales and arm drift and arm strength and ability to rotate and leave them level without drifting. You can do the point-to-point test. Can you touch, my finger to your finger, or your finger to my finger? Can you touch your finger to your nose? All of those things. I do that with my kid every day when I leave. She misses a lot. Dermatomes, area of the skin innervated by these fibers. Again, when you can learn these, and I'll pull one up here. I think you kind of went down that rabbit hole, didn't you? It can be helpful.
I like it. I don't use it that often, but it's useful to know when I do.
There's a good dermatome map. It's on page what? 162 apparently in your book. That'll help you know, hey, if I don't have certain sensation in my cheek, or I don't have certain sensation going across from the right to left side of my chest, of what spinal nerves can be involved. Reflexes. Does anybody here carry a reflex hammer on their truck? Didn't think so. Huh? Don't do that. You can check those if there's some type of injury to those areas. Not doing any of this. Reassessment should be done when?
Depends on how stable or unstable your patient.
Depends on your patient. We do things every 2 to 15 minutes here, depending on what it is. Any type of cardiac arrest patient or RSI patient, we do every 2 to 3 minutes. Unstable but conscious patients, we do every 5, and then your normal people, we do every 15. It's all going to depend on your patient. What are we looking for in those times? Trends is what we're trying to do. Is there any consistent movement up or down? Are they trending, continually going down or continually going up? Did my care or treatment cause this? Or did I start with dog shit and I'm trending down in a good way? Or did I start with dog shit and I'm trending up in a good way? Or did I start okay and now I'm really bad? Because now I need to reassess what I've done and figure out what's happened to change it. Again, continue, just because you do AFU once doesn't mean you don't do it anymore. You should do it after your treatments to say if there's been any deterioration that's made it get worse or increase to make it get better. Whilst most of us don't like talking to strangers, having conversation with your patients is a good way to continually monitor their airway patency. Endotracheal intubation is the best way to secure an airway in a patient with no gag reflex. And if you have the ability and you do have a gag reflex, you take that gag reflex away from them and assist them. And you continually monitor your tube placement. You monitor what it is when you place it. You monitor what it is when you secure it. And you monitor it is, if we're bagging at first and then we put them on a vent, we monitor make sure that after we took the BDM off and put the vent tubing on, it didn't come in or out. And then if there's any type of extreme change in route, that needs to be one of the first things that you look at. I had an end tidal of 40, now it's 9. It's probably dislodged or something to that effect. Breathing rate quality, continue to assess that. A decrease in rate and effort could mean the treatments are effective until it's no too decreased or too effortless. And then it could be that they're ineffective, right? Continue to check their heart rate. Higher it goes up, the worse it is. Consider shock, hypoxia, or a dysrhythmia. Falling rate. Once we went to that 160, 170, 180 range, and then we start trending down and we get to that 40 and 50 range, we're in a real world of hurt. Just go ahead and get your pads out and prepare. Sudden change in rate irregularity is a possible cardiac dysrhythmia or cardiac event or PE event. Loss of peripheral pulses is decompensating shock. That's why I typically, when I check for pulses, I'll go straight to the carotid to make sure I have one. And then I'll check the radial at that point, just because since I know I have the pulses, I don't need to interject anything real quick. Check the radial and see if they have them. If they don't have them, we're either real stage in the shock compensatory mechanism, or their blood pressure is really low and they're going to be into some type of compensating shock, trying to fix that. Skin condition is fairly easy to observe or to reassess. We can just kind of look at the color change. Has it gotten any, does it look like they're sweating? Has it gotten any more red? Has it gotten any more pale? Has it gotten any more blue? Anybody in here ever truly seen the cardiac arrest patient from start to finish, that when you get there, they're shit in color and you get Ross back and they pink up and they become almost red for a minute? I mean, that's what you're looking for, or even the other way where they look normal and now they don't look normal. You want to address all of those things. Transport priorities, that's going to be up to you. Go with your gut. Again, Lulu lights and flashing lights, or Lulu sirens and flashing lights don't really make that much difference. Heavy traffic, absolutely, they make a difference. But, I know our big ass ambulances here, those big 550s, they cap out at 87, too. That's like interstate speed, I think, for most of us. So, if you got one of those nurners in the left-hand lane doing 63 and a quarter, yeah, get them to move. But all you're doing is inhibiting people from getting really old, because most of those people go faster than 82 on the interstate the way it is. So, it helps getting through, but, your miles may vary. Vital signs reveal trends. Again, some monitors have the ability to watch trends on them, some don't. Rising pulse rate combined with falling blood pressure equals shock. That is important to know. Increased heart rate with lowering blood pressure, really bad time. Inversely, decreasing heart rate with raising blood pressure is equally a really bad time. That means you have a stacking intracranial pressure, and it's a good possibility that they are hemorrhaging or about to hemorrhage. What? This? This? Part. You only have 2. That's a biome. But yes, part of it. We'll get into that cardiology. Narrowing pulse pressures with weakening pulse, indicative of cardiac tamponade, tension pneumos, or hypovolemic shock. How do we get our pulse pressure? Systolic and diastolic. This systolic minus diastolic. So if I'm 120 over 80, what's my pulse pressure? 40. What is a acceptable pulse pressure? Anything above what? Anybody? Steeler?
Let's try another one.
20 to 25 is the lowest you want to be. And that, now, it can be those, but some of these people that are, you know, if they're 60/40, that's not a good A blood pressure, obviously. And it's not a good pulse pressure because what's happening in the body when we have narrowing pulse pressure? Think about what the pulse pressure is. Your systolic is what? The force of contraction, right? And then your diastolic is what? Force on relaxation. What's happening when those numbers move closer together?
The blood's not gonna be able to move.
Yeah, it's not moving a whole lot because there's no variational difference. Like if there's only a 10 point, that's just like me going, okay. Because there's not force that it's pushing against, right? Or there's too much force that it's pushing against, so we're only plus 10. We're not making very much headway. Where if it's 120/80, there's a 40-point difference of we're moving and we're not. We're moving and we're not. So the closer that those numbers get together, the less blood is moving down. Focus assessment, obviously we are just focused on what that patient's treatment plan dictates. Just saying, hey, I'm fine minus my broken wrist. Are we gonna do a head to toe on a broken wrist typically? We might initially check just to make sure that's not a distractor, but after that, what are we doing? Focusing on the patient's wrist and stuff that goes along with it. Management plan, evaluate whether your care is working. This is where I said, make a damn decision. How many times did I point that in your head in your class for over 16 months? Make a decision and always have a plan of attack of what you're going to do and have a way out for what you did. Always have that in your head. Anything you're going to treat, have in your head how you undo it. Because again, what are we doing? We're making an educated guess most of the time, right? So don't just get down this rabbit hole. I know it's this, and I'm going to do this, and then I'm going to do this. And then get your point in where you do this, and you go, oh, that was wrong. And now you're sitting here in a panic mode trying to think, what do I do? That's why I get phone calls at 11 o'clock at night. Your anxiety. Right. You evaluate your ABCs, take all your vitals. What is the minimum number of vitals you should have on the transported run? No, that's a bullshit answer.
It's on 5 minutes from Ottoman 2. I still say.
Proximity does not dictate treatment. I've heard 2 and I've heard 3.
I say 3, get 1 on the scene because typically you get 1 in route and then you get 1 when you get there.
I agree with you. Now, for some of the people like my son was for 19 days, ready, they're gonna put a suitcase with you, and they're meeting you at the ambulance. I'm okay with 2 on those people. They won't let me get on the scene. Like they're waiting, ready to go with their Samsonite suitcase, right? But typically, you should get a set on scene, right? You should get a set after you've done something. Very rarely do we just sit there and go, please rate us 5 stars on Yelp. Like you're doing something, right? Even if it's fluids, Zofran, Toradol. And if you are that type of provider that goes, how you doing? You want to rate us on Yelp? You probably have a really shitty Yelp review because you don't provide patient care, you provide a taxi. So, minimum of 3, 2 to 3. And I'm going to emphasize proximity does not dictate treatment. Now, does that mean that you do the same amount of shit that if I'm 5 minutes away from the hospital as I am 35 minutes away from the hospital? No, but it is not an excuse to not do something. I didn't get a blood sugar because we were right around the corner. Okay? So here's what you're gonna do. You're gonna get back in your ambulance and you're gonna drive there. We're gonna stay on the phone. And while you're driving, I'm gonna take this person's blood pressure. And if you don't get there, or blood glucose, and if you don't get there by the time that you get there, or if I don't get it by the time you get there, we got a problem. And how long does it take to do glucose? You better be in the ER bay, where the run should have started for you not to have certain things. Now, again, you have a longer transport time, you have the ability to do more. But you should never use that, I didn't do this because I was here. Now, if you're like, hey, I intubated your patient and I don't have them on the bench because I was so close, it takes a few minutes to set up a vent. So I'm not gonna sit on the scene just to DJ dial my vent to put them on. That's why they're still being bagged. That makes sense, but you still intubated your patient, you still gave them medication, you're still doing certain things, right? But you're still doing as much as you can. You're not withholding because of proximity. I will hit you with a shovel if that is your excuse. Any questions?
So it skipped like the first half of the more chapters.
What? What was the first half? Shut up, Jackie. What was the first half?
Secondary assessment.
What is the secondary assessment? Secondary assessment, I feel like it went over, it probably was not an over. Reassessing, focusing in on your rapid or your focused assessment. Huh?
I think it's good.
Probably. You have homework, don't forget. Questions, concerns, comments? I think I've given you guys maybe 2 packs of these. Anybody have 2 packs? Maybe like 3 or 4 pages. What?
Well, I saw it was not irrigant.
Huh? Is your homework? Next class, we will be doing scenarios. After next class, okay, after next class, you need to start wearing your uniform. We'll get to the point where we'll start taking you on runs. Not just for bullshit, but if it's like, hey, that's not commonly occurring, it would be good exposure. And you will be picked on your participation in activity in class. So, and if I pick you, you don't want to go because you'd rather listen to lecture so you don't miss something that could be on the test. I agree with that, but we will give you the opportunity. Again, it'll be dictated off of your participation and interaction. So if you sit there like a bump on a log, you will continue to sit there. Questions? What? Do you have anything enlightening for this class before they leave?
Reminiscing.
No words of advice?
What class is that count towards right now, or is that just like?